So we move on to Dr. Sudeep Das, who will tell us on how to do SICS in subluxated cataracts. You know, SICS, people say, okay, it is difficult, just do SICS. That is not possible. Just doing SICS in a very difficult situation, this is not at all possible for very novice SICS surgeons. Or people who don't know SICS say, only phaco, but in between, when there is subluxation, we'll just do SICS. It is not possible to do good SICS. So, how to get the advantage of SICS by practicing well in regular cases and the modifications required? Dr. Sudeep, nobody better than Sudeep to explain on this. Over to you, Sudeep, please.
Thank you, Meenu, for having me here. Wonderful. Always love coming to KSOS. So, precautions to take in subluxated cataracts. If there is a very gross dislocated, subluxated, then don't even plan for anything. Plan for ICC, SFIL, iris claw, whatever you're comfortable. Use hooks to support the areas of zonular dehiscence. It doesn't have to be all 360 degrees in all cases. And AC, one thing one should remember in all these problem cases, including subluxation, the AC should never become flat or excessively deep. So I had a case where, I think I'd sent a video to Matthew, where I had hooks and I injected a lot of viscoelastics. The lens went against the hook and it broke because the lens moved back against the hooks. So rexes should be adequately sized for easy delivery of the nucleus out of the bag. Preferably use sandwich, an implant CTR. If there is, even after the IOL implantation, if you see a distortion of the bag, ovalization of the rexes, put in a CTR. An IOL can be placed in bag many of the cases, but choose a 3-piece IOL if implanting in the sulcus. So this was a traumatic subluxated cataract. So you can see there's a localized zonular loss in one side, and you can see folding of the rexis or the capsule also when I'm doing the rexis. So I always prefer going through. You can see how it's sort of, there is a sort of a fold there when I'm doing the rexis. So these are, I'm making these very scleral openings. This I learned from Dr. Chi Sun Fake from SNEC. So when I need, I will use these hooks, but I don't want to lift up the bag and the anterior capsule. So I want them to be more scleral, very close to the capsular bag. So as you see, these are not the same as what we use for pupillary dilatation. These are iris hooks, but they're gone in very, very posteriorly. So they don't actually lift it up. And don't tighten the hooks very much because these are not long hooks. You don't want them to go up to the equator. So they're sort of just supporting the bag. And there's one, so there are 5 of them. One of them is going behind the SICS tunnel superiorly. So this is what it looks like. And then extend the wound. So this is like a pentagon. The nucleus has come out. Be careful at this stage because you can still rupture the capsule, the margin. This is not a very hard cataract, but it is a formed cataract. So this was, like I said, it's not a very hard cataract. I could actually remove it with viscoelastic itself. But if it's much harder than this, then yes, use sandwich or whatever. No reason that you can't use Simcoe through one of the side ports, but I don't use a Simcoe ever in my life. I use a bimanual for everything. So here be careful how much viscoelastic you insert. If you put too much of it, then the bag is going to tear. And this was a sort of a traumatic subluxation, so I don't expect the zonulopathy to become any worse. So I'm putting this IOL in the bag itself. So and actually later on I put a CTR also in this because of ovalization. I won't go to that. This is a really tiny pupil, so I really don't know what to expect in this. So I put in, and once I started doing the rexis, realized that the zonules are also weak. So actually why I wanted to show this is you can shift the hooks from the iris to the rhexis margin and support the bag also in cases like this. And if you see, I trimmed the hook on that side, because if I don't, it will keep touching the eyelid and the hook will keep coming out of the bag. So we trim it so that it doesn't touch the lid. Then again, after that it was routine. Did a sandwich and put the IOL in the bag. And this is a case where it's, as you can see, it's sort of a hypermature. You can see it's very difficult making even the initial nick. It's a sort of a Morgagnian cataract, zonules are weak. So here I wouldn't actually do a rhexis. So make a small hole. You can use two lance tip blades also to make the initial opening. And then you can, here I actually tore the lower part of the capsule, but sometimes I support the bag with the capsule with my left hand and use micro scissors with the other hand and cut it off. So whole thing is there. Here if you do a rhexis, then the process of dislocating the nucleus from the bag will be even more traumatic. So basically just remove it with viscoelastic. It's a tiny nucleus, and then pull it out with Vectis. There's no cortex, so I'll put the lens, 3-piece lens in the sulcus, and then remove the viscoelastic. So always have a bunch of 3-piece IOLs so that I can do this. So these I will not implant anything in the bag. This was a long-term traumatic subluxation again. So there's one area where you can see the zonular dialysis. The rest of the capsule is actually, the zonules are all right. So I thought there was a gap there, so I sort of injected viscoelastic there to prevent the vitreous from coming out. Then tried staining the rest of the capsule. But some of these calcified fibrosed capsules don't actually stain very well. But here you can see the folds in the capsule. So it's really thick, it's like a cardboard. And this is absolutely no way that I can cut this. So just make an opening wherever one can, and then use scissors for the rest. But as you can see, the rest of the zonules are pretty all right here. So basically, it's on the nasal side that the zonules are gone. So cut that capsule off, remove that bit of cardboard, and I'm trying to dislocate whatever I can. So you can see even the nucleus is shaped like a bean and sort of comes out. And then I'm wondering where to implant the IOL. So use a 3-piece IOL. I can't implant one haptic on this side. So I think I can probably try to separate this out and place it in the bag, but then the IOL doesn't really center. So this is in the, at least that part is in the bag. But I'm trying to see if I can manipulate that fibrosed capsule and get it to open, which is impossible. So it's so thick, I'm not worried about it giving way, and there's no zonules on that side. So I'm just trying to see if there's some way I can, but then decided it wasn't going to work. So I just tried to cut out as much of the remaining capsule from that side as possible. And trying to sort of manipulate it into the sulcus. And that's probably just about the best that I can get, but we compare it with normal. So it's fairly centered, and as you can see, the center is sort of all right. Thank you.
Thank you, Dr. Sudeep. Actually, SICS, doing SICS, there are some modifications which you definitely highlighted. And thank you very much for showing all those hooks and the use of all the instruments. I think the next talk is also on that. But what I wanted to tell was, if you, just pointing out, you can have micro scissors and micro forceps also in hand. Doesn't mean that just because you have a large incision, you have to go through that incision with larger instruments like vanas. See, always you can go through a paracentesis and cut at a different angle. So you will be able to cut these kind of capsules and other things, or hold onto the capsule differently from a different angle. So a micro incision scissors and forceps will be useful also, and also the use of viscoat and sodium hyaluronate. That is also very crucial, because when you are entering into the chamber will remain much formed, and also it can, this dispersive viscoelastics can plug your area of zonal dialysis and prevent further egress of viscoelastics.